No, that's all right.
I don't remember exactly what street. It took me back over there about 10 years ago. This is where. Yeah.
This is. They got that one.
Yeah. Pretty much every single type of food, right?
Walk around the corner.
Yeah. Like one type of food. So it's 4 blocks of right.
In her apartment building. Really good.
Perfect. How's that? See if it'll play it.
What would you say?
Non-productive.
Non-productive?
The liver still don't work, 23 still doesn't work. What else can I say?
They didn't fix it over there.
No, they didn't. Did not fix it, what's it called? They may have to fix it by 8:30 tonight. I found out what was wrong with the door lever thing. The door pulled and messed it up.
Oh, that's probably actually coming off of my computer.
It disconnected that.
Can we end your show right now? It's just so, I'm not sure if we'll be able to let other people. I just want to make sure that.
Okay, just fine.
What's it here?
Well, why do you need your name? Instead of the street.
What? I don't know what you're talking about. Oh, you were?
Sure.
I worked at.
Yeah, it's like everybody's become a telecommuter, teleworker.
Source here, right?
When I was in Boston, we did 4 days a
I was
week.
working with a day, that's why I called
We ran
it. You got it.
half.
Everybody wants to use my cosign.
That's because everyone from Yale to
Everybody's like.
Yale to University of Vermont.
You have to. All right, cool. Thanks for calling.
Whole swap.
Well, that's what I thought, I was like.
It's interesting. It was a learning process. There's
Oh,
how do
you
you
did that on purpose.
corral 65 dots.
Yeah,
to-
It's the same bad thing.
You were in Israel at that time? Was that-
No. I went to med school in Israel. I did my interventional training. I got this with weakness, which is like one of the hardest
It's like,
kind of
oh, this
dental
story,
schools.
well, it makes sense why he went to James, because he had James.
Why
The
Israel?
first one was all
A
the.
bunch of family. From an uncle who
No, my first
studied
name came, my middle name
cancer
came.
immunology out there.
My dad's first name is James, and his dad's first name is James, so.
My study abroad was at the NIH.
I lived in a kibbutz for,
Oh, no kidding. Whereabouts?
basically right near Ashkelon.
Mm-hmm.
It was, called Hebrew Kibbutz, BLROT. It was awesome.
You speak Hebrew?
Yeah. I was really hoping I would, but I don't know.
Hey.
But, everybody spoke English there.
Or-
Yeah. I had a fantastic time. That was neat.
Yeah. No, I mean, probably was super fun. We were supposed to go back in my summer. Just, COVID, a lot of it happened, but.
So Dave, how do you get people to come on Friday night?
Well, okay, so that was a
Yeah,
tactical.
must have either an
tactical-
incentive or,
That's what I said, pizza and beer.
oh, he gets to drink beer, nice.
So this meeting will be recorded. It's required for all employees to attend. But,
Yeah.
now, but I'm hoping the attendance is good. I apologize for that.
No.
And, we do a bunch of people on shift. Howard, we check the cars out and cars in.
There's 3 out right now.
3 out.
Station Flores asked me to come.
So we have the city fire station coming in right now. We also invited the rural fire and the Missouri fire.
I sent it to both Blaine and Jason at the low fire. And I did send it to Tammy.
To Tanner, yeah.
Zip drive here.
Do
Oh, I was just gonna get a little zip drive and try and make it as exciting as possible. Color and blue
I?
things.
Well, there you go. Do you, Dr. Minor, are you gonna use your computer?
No, I'm gonna just give it to, you're gonna let him load it up in yours. And you can keep it close.
You're gonna go first then?
I think so.
Sure.
All right.
All right.
When's this, does it start at 6?
It starts at 6, we'll do a little operational stuff, just. Couple of
No.
months. Rolling.
I didn't know it. I got here at 1 and I was like,
Load my
where is
computer.
everybody?
We are good.
Probably 9.
We tested it.
Hey, folks, that are in the waiting area, we'll just have us on mute, but we'll get started right at 6. No, I was like, yeah. Is, have you ever missed a training?
I didn't go to the last one.
You have, didn't you? For medics and aides and people endorsements, we have this registration back here at Town Hall, and now that all of that will be.
I have not, no, I spoke to, oh boy, what? Adrian, yeah. So I chatted with her about that. I think she just said, yeah, interesting. Kind of the same response. Yeah, I think it isn't.
For me, I'm not worried about it. I realize I don't do a lot of
So just, you know, this, yeah, he's. Take a chair, like, you know, what it's like.
No, so I was in part of Southern.
Yeah.
Make sure you sign in if you haven't.
We will have food coming and going.
Hold on.
Yeah.
I can let people in back here if you want to leave that full screen.
Oh, so you're saying you can run from back there? So you want to take over?
Sure.
And if you want to unmute so you can start talking.
I think I'm unmuted from up front.
Load me up.
What's that?
You wanna load me up?
Yeah, I've not done that yet just because he's using my computer.
Oh, can we load up real quick? Before
Yeah.
we get started?
Maybe the easiest thing to do is
Oh, there you go, yeah.
Let's just present. So.
I didn't hear that. Is that secret? He was very good about the whole time.
Okay, so. And then can we unmute?
Yeah, where's your microphone?
Okay.
Because they should be able to hear me off of this computer and I can turn the volume up here.
Our microphone attached to the camera. So you're
It's
good.
over here.
You're talking, yeah.
Okay.
If you want to mute yours and just use this one.
Yeah, either way, whatever's, I mean, it's all. Let's see.
There we go.
Can we hear other people?
If they unmute and come on. So everyone, can you please just say hello? We have Dr. Kala and Dr. Minor with us tonight and for some cardiovascular emergencies, but they're also gonna fill us in a little bit about what's new and exciting over in the community. So,
Just talk, talk up here. Can you hear me better?
Sure.
That one's muted. So.
can you hear us here?
Right, thank you so much for playing. We will,
So, I was a EMT and a medic, I went to medical school, so I'm the newest crew, Dr. Minor, Dr. Weiss, and Silva, part of the clinic group of the community, and I'm an interventional radiologist by training, did my general radiology training, Maine Medical School, which is a big kind of tertiary care center for the state of Maine and most of New Hampshire. And then did my interventional training down in Boston, and ultimately came in here with, because of the opportunity to build a program and trying to develop things to it for a community. So I spent most of my time here. I spent some time over in Billings. That's kind of the scoop there. But I guess from my early time, I thought I was going to be an engineer and still working on the ambulance. Just absolutely fell in love with it, and that's ultimately kind of where things went. I was fluctuated between emergency medicine and trauma surgery, and ultimately, as a med student, sometimes that's just where I want to be. So I'm happy to kind of chat at any point. It's not totally going to be the systems processes for semi-care. I think when we think about things in medicine, in adult medicine in particular, there's really three major emergencies and three major sensitive. It's trauma, and I guess it's consider vascular catastrophes in that section, that sort of stuff. And then stroke and acute heart attack. And I'll kind of touch a little bit on what the numbers are, why I apply those. But I'm going to speak probably about somewhere in the range of half an hour, 25 minutes. I think that's what I really think about this. And we're certainly welcome to any questions that any, so don't hesitate to ask questions, whatever the case may be. And same thing for folks remotely. If you want to unmute yourself and ask a question or clarify. But just kind of run through differential diagnosis and things that I'm thinking about. Strategies, and I really left that very broad, and I'll kind of touch a little bit on that. review of the guidelines, and the guidelines for STEMI care, the most recent ones are actually out of Europe, so 2020. But the guidelines haven't really changed that much. At the end of the day, most of the evidence for the things that I'm going to discuss was really laid down, over the past 20 years. And, I would say major advent in STEMI and now transition growing to the risk is our preferred access type. But the reality is that the systems process, which is really what things that you guys care about, what happens to get the patient into the hospital? What are you thinking about? What are the complications? None of that's changed. That's really stayed, somewhat similar. So this is, symptoms suggested with acute coronary syndrome, and there's obviously a number of different things, but certainly my role as the cardiologist, you kind of get the majority of the slide. But chronic stable remission, meaning, hey, I know I have heart disease. Walk up, a flight of stairs. Walk up one flight of stairs, I'm okay. But by the time I get halfway up the second flight of stairs, I get chest pain, chest pressure, heaviness, shortness of breath, that sort of stuff. And that's still, and that's a presentation that's been there. Oftentimes has been worked up. I cut a half of wood at a time, but when I get on to the final, 2/3, that's really stuff. Possible acute coronary syndrome is evolving. Okay, I was feeling okay, but now I get stuttering chest pain at rest, or get chest heaviness, indigestion, burping, pain in the scapulas, pain down the left arm, for example, sometimes down the right arm. That's possible ACS. And then definite ACS, at least in the really early initial diagnosis, really hinges on the EKG. The definition includes biomarkers, but that's really irrelevant to basically everybody who's sitting there because you don't have that information in the ambulance. So it really hinges on the ECG. And we'll chat a little bit about that. And I'm not going to go into so much of, how do you see a STEMI on an EKG. I think most people, having gone through the paramedic course or, certainly been in that realm are exposed to that. But we will touch a little bit on that. But why do we care? So STEMIs, in fact, are going down as a proportion of total heart attacks. So STEMIs, generally speaking, are going down as a proportion of total heart attacks, and frankly, the incidence in the population is going down. But nevertheless, it is an event that carries with it a very significant one-year mortality, and that really hasn't shifted a whole lot, kind of in the modern era. So since we started using stents and balloons to open up an artery, this really has not significantly changed. The thing that has changed is that we've gotten much better at driving the patients down to the right side of the screen. So drive to the left side of the screen, rather. So trying to minimize the ischemic time, making sure we're conscientious of where the people are going to get reperfused, recognizing the value of reperfusion. We'll touch a little bit on that. And that has been, that's one of the major advents. And this is kind of the ACC or AHA, chain of life, early symptom recognition, call for help. Some of that's on us in terms of community education. It's certainly, the events, the big sign that's in front of the good food store, call 911, don't wait if you have heart pain. Heart attacks, don't wait. There's been big efforts with COVID in particular. Heart attacks kind of disappeared for a little while. And I don't know if you guys experienced that as much. Yeah, but in Boston, in like April, we did no heart attacks. It was just like people stopped having heart attacks. It wasn't, of course, that they stopped having heart attacks, but they were waiting. And sure enough, then you started to see the late complications, mechanical disruption, that sort of stuff. So early symptom recognition, calling for help, because the ischemic time doesn't really care what time the ambulance gets there. It doesn't care what time the patient shows up in the ER. It cares when the artery gets blocked, and that's an important concept. And trying to minimize that amount of time that, hey, if your standard, stable angina, is not coming on at rest, and then, hey, now you're getting that angina at rest, and it's getting worse, and it's getting worse, that's a problem, and that's an emergency, and making sure people are up to speed on that. EMS evaluation and treatment, we'll touch a fair bit more on that over the next probably 15 minutes or so. ED emergency department evaluation and treatment, I'm going to skip a little bit on that and we'll touch on it really only insofar as it involves transport. And reperfusion therapy I'll touch on. And this is my little kind of doodle on top of the graph. It is true, it doesn't just get steeper and steeper, that at some point there is a period at which people have kind of become survivors, in that, if you survive your heart attack out a day, then more likely than not, it's not that, so the difference here, I guess the point what I'm trying to convey is that the difference between, say 4 hours and 5 hours is significant with respect to mortality, but the difference between 19 hours and 20 hours is not, right? The mortality is high if you have an event. But once we start to get out 19 to 20 hours or 19 hours to 19 hours and 15 minutes, that is what it is.
That's time to reperfusion, is that what that?
This is total ischemic time. So the important point here is that we don't get people here. You guys don't get people here. I might get people here if they were in the operating room and started to get chest pressure in the post-op area or something like that. But by and large, you get people here or here or here, where they're 4 hours into their event. And guess what? As the minutes tick by, the mortality starts to go up. You get a couple point increase in mortality, and it's a difference of 1 in 20 people, for example, which is is something that's important. So again, we touched on that chain of survival, or kind of chain to reperfusion, and that's that's again a concept that really holds true from the time the person picks up the phone until the time they get to the hospital. Now, once we know about a heart attack, then what? And there's really 2 different options, and this was certainly true. In Maine, our center did about 450 STEMIs a year. It was about half licensed. Many of those were flown in from, 400 miles away. I mean, it was really, very sort of rural catchment area, much like it is here. We get people from, anywhere from Deer Lodge to, Granite County. So that's not really that uncommon. But in that whole catchment area, we have both a combination of PCI capable and PCI non-capable hospitals. So obviously, we have 2 PCI capable hospitals here, and then when you start to go out, in the surrounding communities, whether it's Ronan or Colson or, Marcus Daly, Deer Lodge, Granite, all of those are going to be, by and large, Lytic hospitals. And particularly, when you throw in icy roads and, nighttime, bad weather, that sort of stuff. So there's really 2 primary strategies. If the patient is initially seen at PCI capable hospital, patient should go to the cath lab. If they're having a STEMI, that's very clear. You should be at the cath lab. You should be there from the first medical contact, meaning the time that the ambulance is having contact in the person's house, until the time I'm putting a device in. So that means the patient got from their house, they got into the stair chair, they made it down the stairs, they got out to the ambulance, they dug through the snowbank to get the patient in. They put it down, they didn't slide off the road, they went to the hospital, they got unloaded, the diagnosis was confirmed, some of the preliminary stuff, have you bled, are you allergic to aspirin? We take our angiogram, we figure out what we got to fix, and then we pick out the device to do it. So all that stuff has to happen within an hour and a half. And then typically, the preferred mechanism, and this is important, is PCI. CABG in the setting of an acute myocardial infarction is very, very high risk. It's not to say it doesn't happen. It happens, fortunately, exceedingly rarely. The preferred treatment algorithm is, that you take the person to the cath lab and then you open it up with PCI. Now, if you're anywhere outside of Missoula, then you run into this initially seen at a non-PCI capable hospital. In that case, the first medical contact to device time gets a little bit longer, a little bit more permissive. So you have 120 minutes in that sort of a situation. But that's acknowledging that there's time for the patient to get evaluated at that outside hospital, hopefully in and out within 30 minutes there. Or alternatively, if that's not feasible, then to give thrombolytic therapy, clot busting medication within 30 minutes. And then from there, the patient needs to go to a PCI capable facility. This is just a little bit of data. This was actually an article that was published by one of my mentors from back in Boston. But this is people who were transferred for PCI versus people who underwent on-site fibrinolytic therapy. And it's 9,500 matched people. And you can see, in terms of bad things happening to people, generally speaking, people do better if they get PCI. And that's part of the reason we have PCI centers. And frankly, part of the reason that we move people. But that trade-off is not, that trade-off is time sensitive. And this is, so here on the bottom, you have PCI-related delay, okay? This is either door to balloon or door to needle. And you have odds of death with fibrolytics, okay? So you can see that if you're less than 120 minutes, your odds of death if somebody's treated with fibrolytics over PCI therapy is actually higher, 2 to 3 times higher, okay? That, of course, changes as you get out further, where it is advisable to get the artery open in whatever way that you can. So that's a little bit about the background.
Can you stop there for a second?
Yeah.
One thing I want to emphasize to you guys that the drip and ship, giving them thrombolytics, transferring them is really the gold standard of care. The number one best thing to do if they're more than an hour and a half or 2 hours out. So that means Deer Lodge, sometimes Hamilton, Marcus Daly. In bad roads, it might even be, St. Luke's. And you saw in those curves, if you go back, that if you're more than 2 hours out, you're not going to benefit as much from PCI therapy alone. So when I first came here 5 years ago, nobody was giving thrombolytics, and I was like, what? Because in the first few cases that we gave them to, they had reperfusion as they were leaving the emergency department. And they had their 2 hour drive ahead of them, but they had their arteries open. So we do really feel and hope you guys will see a lot more patients getting thrombolysis, especially when you've got, it's going to be a 2 hour delay, until we can actually get the artery open, because that's really considered the gold standard of therapy. And I was really surprised that wasn't done here when I came here. We're trying to change that.
So this is, I talked a little bit about system stuff, and this is kind of highlights things. But basically acquiring pre-hospital EKGs, that's one of the biggest ways that you can reduce time, because it takes me time to drive into the hospital, particularly if it's off hours. If I have another patient on the table, I got to take them off the table. We got to get the other lab ready. We got to, there are logistics that have to happen. The lab isn't always sitting there with the staff ready to go. So pre-hospital EKGs, early recognition, and then, I would argue that this is probably the biggest one. So paramedic interpretation of the pre-hospital EKG, clinical presentation, and the clinical presentation to consider activation of the cath lab from the field. So, it's a topic that's been studied. Apparently in Los Angeles, they are about 50% accurate. I can tell you in Maine, the paramedics are about 90% accurate. To the point where we had a program in the southern part of the state where the paramedics would actually bring the patient, rather than to the nearest community hospital, they would actually bring them to the airport and load them on an ambulance before they had ever been, load them on a helicopter before they had ever been seen by a doc. And we were able to extend the kind of territory for primary PCI using that strategy. It had to be VFR, it had to be visual flight rules. It couldn't be an instrument flight day. It couldn't be low clouds. It couldn't be fog or icing. It had to be daytime. But if those things were satisfied, it was good weather, the helicopter was there, they would go right to the airport and fly in. They'd be in about 12 minutes. So we don't have that here yet, but it is certainly something that's on my radar screen when you start to think about outside places and how can we better serve the community around. This is, again, straight out of the guidelines, checklist for improving door-to-device times, and pre-hospital EKG used to diagnose STEMI and activate the team while the patient's en route to the hospital. So my message is, if you think you have a STEMI, call it and get the team there. And nobody who goes into our line of work cares if it's not a STEMI. I suspect, that our numbers would be as good as they were in Maine if I had to take a guess. That 90% of the time, appropriate activation. That means that all of those activations have significantly reduced by about half an hour the time that the patient's ischemic. So don't hesitate to do that. Thrombolytics, I'm going to just touch real quickly on the two strategies, and then I'll show a couple of cases and probably turn the floor over here. But two strategies, I kind of, we've been dancing around with this so far the whole time, but thrombolytics versus primary PCI. People say, well, geez, if I get thrombolyzed, what's my risk of bleeding? What's my risk of, opening up the artery? Because those are the two competing interests here. I would love to have a medication that we give it to somebody, it opens 100% of the arteries and it doesn't cause any bleeding. That's the perfect medication, but we don't have that. The reality is that when we give thrombolytics for heart attack, the risk of bleeding in the head, which is really the bleeding I care about, is much, much lower than when you give it for stroke. And the reason being is that you don't have damaged brain that you're giving this clot busting medication to. You have a healthy brain and a heart that's ailing. So tenecteplase, which is generally what we use around here, 85% patency rate at 90 minutes, which means that 85% of the time people come in and they're starting to feel better. You've aborted the heart attack. There's not more heart muscle dying per se. You may introduce the element of reperfusion arrhythmias, for example, and we'll touch a little bit on that. But 85% of the time you've stopped the heart attack. And guess what? If you haven't, 15% of the time, if you haven't stopped the heart attack, you're rolling into the cath lab and ready to go. So this is really why we touched on that. This is a tiny slide for anybody who is sitting further than I am. But basically, absolute contraindications, history of bleeding into the brain, history of AV malformations, history of a neoplasm or a cancer in your brain, history of an ischemic stroke within 3 months, except if it's within 4.5 hours, suspected aortic dissection, active bleeding, closed head trauma within 3 months, intracranial surgery within 2 months, severe uncontrolled hypertension, and for streptokinase, which is really irrelevant, prior treatment within the last 6 months.
Dr. Kelly, is there a reason that we should collect this information in the field for you, or is this only?
It's less relevant for me because I'm not going to lice somebody.
Exactly.
But you do want to know, kind of what you're thinking about, and particularly if somebody's doing a shift down in Hamilton. Because this information is going to be the information that the ER doc is going to need to know when you walk in, because in the perfect world, and I have no idea if this is how it's done in Hamilton, but in the perfect world, a patient doesn't leave the local EMS stretcher. They come in, they get their EKG, they get evaluated for these things, they get lysed, and they should be back out the door within about 10 to 15 minutes. On the same stretcher with the same crew. You got somebody in here may know, I don't know how Hamilton does it, for example, or, so this is just kind of my I think, kind of concluding thoughts here, and then we'll transition to a couple of cases. But EMS considerations after thrombolytics. So medications, this is really, really important. In addition to thrombolytics, people need to get their aspirin, 324, 325. Some people say 162, but generally 324 of aspirin, 4 baby aspirins or 1 full dose aspirin. They need to get Plavix. The Plavix dose when people are getting thrombolysis is 300 milligrams, which is different than the standard loading dose of 600 milligrams. And it drops to 75 milligrams for people over the age of 75. Perhaps most importantly, they need to get heparin. Right? The clot busting medicines all work by breaking up the clot, but they don't work for that long. And when you have a heart attack or a heart artery, which has got a cholesterol plaque that's torn open, that cholesterol crystal inside is exposed to the bloodstream and attracting blood clot to it, that, you know, it's nice we can block off the clot that's overlying the top, but we have to protect that vulnerable plaque until we can, you know, get it stabilized in the cath lab with a stent. So heparin is important. And if you were to send somebody off of heparin, even from a relatively local community, it would not be surprising to me that they would, you know, they got an 85% chance of reperfusing, but then they would go ahead and thrombose again. So that is important. And fluids, and we can, that's a whole nother topic, but making sure you have access, and ideally having your access established before you give thrombolytics. Any IV that fell out, any pokes that the person got, all of them are gonna bleed. It's not life-threatening bleeding. Patients are gonna be like, you know, annoyed. The gums will bleed, they'll get gingival bleeding, but it's not life-threatening generally.
One more question. So just if you have a patient who takes a baby aspirin in the morning, and you get there at 6 at night, what's the time frame for the 324?
I'd give it.
Just give the whole 324.
Yeah. I don't know if there's any local protocol, but I would give it. If you haven't given it, I'll give it as soon as they get to the hospital.
When you are in there with the catheter, you guys actually pull clots and fragments out?
Yeah. So I'll show you a couple of cases here in just a minute, but we have a couple of different technologies that do it. And the simplest one is literally just a tube with a syringe and and it has a special tip on it that allows it to follow our wires. And so basically the wire is kind of the train tracks that allow the equipment to go where you want it to go down the right artery and not down the other one. So the simplest thing is literally just a suction catheter. More complex, we have a machine that actually breaks up the clot and basically sucks it out. And both of those are available and can be used. We don't use it routinely. There's actually evidence for harm if you were to use it routinely. But I don't know if you don't have a case of, I don't have a case in here, aspiration, but it's done relatively routinely. Not on every case, but when you need it. I said avoid the right hand if possible. I remember as a EMT, as a medic, I guess it was, asking an ER doc, like, do you care where I put the IV? But this is one time I actually do kind of care. And the reason is because when people are done with their cath, they get this little bracelet here. And that basically has an inflatable air pillow and holds pressure over the access site. Probably 9 times out of 10, we're going to use the right wrist. So if you have an option to put an IV somewhere else and you don't care, then I'd appreciate it. If you really don't have an option, don't go to sleep over it. Primary PCI, this is maybe a little bit less relevant in this sort of discussion, but you know, when we think about all these things, you should, you shouldn't, you can or you can't do it. All of this kind of gets graded out into our guidelines, into the physician level guidelines. And it basically has to do with the extent of the benefit as compared to the risk, and it has to do with the level of evidence. So something like, you know, treating people in the cath lab for a heart attack, that's a level 1 class 1 level A guideline. Things like wearing a parachute when you jump out of an airplane, that's going to be a class 1, meaning the benefit is greatly bigger than the risk. But level C, there's no real randomized trial to suggest that you should do that, but I don't really need a randomized trial for something like that. So, again, just to kind of review from a primary PCI strategy, so ischemic symptoms less than 12 hours is a 1A, as I mentioned. Ischemic symptoms less than 12 hours, contraindications to fibrolytic therapy, regardless of the time delay, again, 1B in this case. Cardiogenic shock or evidence of hemodynamic instability, 1B. Evidence of ongoing, so we like to open people early, as I've alluded to. But if people have evidence of ongoing ischemia, they haven't proven themselves to be that survivor, that they're still having, whether it's runs of VT or something like that, we'll open them later. I think that's all I'm going to comment on that, and we'll get to a couple of cases, and I'll hand the floor over. So this is a case I did here a couple months ago now, 2 or 3 months ago now. 49-year-old truck driver, no prior cardiac history, developed stuttering, chest pain 1 day prior, kind of off and on and off and on. He said, I have indigestion. He said, I have, ate too much pizza, whatever. And the pain resolved, and then he was driving down Route 90, and about an hour and a half before he presented to the hospital, developed a recurrence of chest pain, and it didn't go away. Again, young guy, didn't really think a whole lot of it, but then it got worse and worse and worse. I'll throw this slide in a couple times here, just as we're kind of talking about the EKGs. But this is his EKG, and I apologize for the scan. But any comments about this?
Yeah, where's the heart attack, guys?
So I'd say a couple things when you look at an EKG. So the first thing is, what's the rhythm? What's the rate? And what else is going on? I'm going to just kind of leave it at that. So you can see, like a LifePak or any other EKG, standard EKG machine, you can see down here there's small P waves in the inferior. This is a lead 2 strip, inferior leads, P wave here, P wave here, P wave here. Okay, so it's a sinus rhythm. It's a reasonable rate. We can count out the boxes, but I'll save you that. There's occasional ventricular beats, okay, but singlets, not couplets, not runs of VT. And then perhaps most striking to me is you see that ST segments here are really tombstoned. I mean, this represents an acute MI. And if I go back to the prior slide here, the leads that are involved are going to be V3, V4, less so V2, but V3, V4, V5. And then if you look over here in the inferior leads, it's kind of hard to say whether there's maybe a little bit of ST depression, maybe AVF in lead 3. So again, 3, 4, a little bit of 2. In this case, it was 5, but that just has to do with where somebody's stuck on the sticker. So the diagnosis here is guy having chest pain with this EKG is STEMI, right? Anterior STEMI to be more specific. So your life flight? Yeah, so he got loaded up. They pushed the easy button.
Nice.
And they called me at the same time, which is exactly how it's supposed to happen. Get the resources rolling. And he got loaded up, and this is our first angiogram here. And let's see, it's not playing super smoothly. But basically what we do, in this case, we were working through the wrist. This is kind of like me sitting here. Okay, this is kind of the projection. So the catheter comes from the wrist, comes up here through the subclavian, sits at the aortic root, and then injects X-ray dye. And then you'll see, and this is a standard first shot, which is kind of a view from down on the right side. This is what we call the circumflex artery. And then coming out here, and it's not a great view to see it, is going to be the diagonals and the LAD. And so obviously, as you guys pointed out, I'm worried about the LAD in this guy having anterior MI. Oh, and it's not showing at all, huh?
Slowly.
Really, really slowly. Huh. Well. That's less exciting if you can't see it. I guess you could see it on this one. I don't know, it seems like the Wi-Fi just slowed down. But anyways, so what you can see here, or what you don't see, is the LED. And so here's the right coronary artery. The right coronary artery typically forms a C in the standard projection. And that looks, for those of us in the house here, you can see that it actually, in fact, looks okay. And so what we did in this sort of situation, you can see I now have a wire down, and I had a pretty good idea where that LED was, but you'll see I didn't know exactly. And you can see now just a little bit of a hint of dye that's kind of starting to sneak out through over here. Now it's really just stopped up. I might take 2 seconds and see if I can't plug it in here, and at least it'll project better. Sorry about that.
So guys, getting back to the EKG, you know, cardiologists can read EKGs in about 3 seconds because we look for patterns. So if you remember where the leads go, V1, V2, V3, V4, that's the front of your heart, the anterior wall. So the yeah, that is me for a long time. That's kind of what the EKG changers or. Now I think this is not. This is a, this is a 30-year-old who's got atypical chest pain. I think it just shows some early repolarization, but otherwise normal. So, yeah, I mean, I'm really keen on seeing that with you and helping, especially if you guys have a question. We'd rather you contact us or another cardiology team and let them see it on their cell phone. Yeah.
Okay, we can see it. Sorry about that. I don't know, hopefully, oh, you know what, they won't be able to see it unless.
Give us just a second, guys, to get it readjusted.
So talking about thrombolytics, let's say you've got SC elevation, you're like, damn, there's a big snowstorm, we're not gonna be able to get the patient to a STEMI hospital for a couple hours. Do that, you know, we're gonna avoid that complication because we're seeing escalation everywhere. It's not just in the anterior or inferior or somewhere else.
All right, we are way back in action here.
So we're gonna talk a little bit more about radial access, but I think I'm gonna convince you guys, if you have a heart attack, you do not want them going in your blood. And really, it's the future of our specialty, and I do both endovascular and coronary, is we try to do every single case of the rest. There's some really good reasons for that, and I'll go over that.
So unfortunately, it's not projecting that well for people remote, but so here you can see wire comes down here. I told you that's kind of like our train tracks, basically allows the equipment to go where it's supposed to go. You can see the two markers here for our balloon. And just for the sake of time, I've cut out some of the balloon inflations, but you'll start to see now that, hey, it dye's starting to get down that LAD. And you can see that, in fact, I'm in this little septal perforator branch, which that's okay, no big deal. We'll reposition the wire, do a little bit more balloon work up top there. And now we can kind of see what we're dealing with. And here comes a stent. And there's the stent going in. And this whole artery wasn't here, right? So that's the very first shot that I showed you. And this is what things look like when they're opened up, same projection. And then again, the slightly different projection, I said this is a standard projection with the circumflex coming down here, LAD running out here, and you can see the stent is here, and now that artery is wide open. So that guy's heart attack was stopped, and you know, frankly, the early activation, the helicopter being launched even before the cath lab was activated, but they were ready to go. The team was there. Guy was done in something like 95 minutes after going to an outside hospital, including his air transfer. So, you know, this is really why we do it. This is why we do it. And this is, you know, this is going to be really good for that guy. And the system worked exactly as it's supposed to for him. Second case, 79-year-old guy, history of multivessel coronary artery disease, had a 4-vessel bypass over here. Hyperlipidemia, prostate cancer, has an indwelling catheter, goes to the outside hospital, pressure type chest discomfort, which started at approximately 10 a.m. Now, you remember what I said about where we end up finding ourselves on that ischemic time chart? We end up finding ourselves in the steep part of the curve, right? This guy had 10 a.m. chest pain when I met him. You know, we're already, 5 hours into it. We're right in that steep part of the curve. So time is muscle in this sort of circumstance, and minutes really matter. You know, again, the same slide that you saw before. Here's his EKG. Thoughts about that? Anybody want to volunteer on this one? Inferior, right? So you see precordial leads have a little bit actually ST depression. V3 is a little bit funky here, but 3 and AVF here, you know, certainly look like they're up. I'll tell you, when he came in, the guy's totally pain-free. He got lysed at the outside hospital. This EKG, one can debate whether or not it's a qualifying EKG, but for him, he got lysed. His left radial, which is what I need to use if I'm going to go up and shoot his lima, was harvested as one of his one of his graft conduits. So he has no left radial, which means we're in the burn. And by the way, the guy takes a Pixaban on a routine basis too. So in this case, I actually kicked the ball down the road 24 hours, let the Pixaban wash out, and I took this first shot. And this is the same projection that you saw before, right? Here comes the circumflex down. Here's the LAD out here, and you'll see a little bit of filling down here, but this is kind of weird. What's that thing there? And I'll give you a hint. This gives you a clue about it, right? Well, the guy had a history of bypass, right? That's his lima, but the lima is supposed to be supplying blood from the subclavian down to the heart. And here the heart's supplying blood to the arm. That's a problem. So here we go. We took some pictures. There you can see the blood going all the way out the arm. So he's getting his arm blood flow both via the vertebral, which I haven't shown you, but also predominantly through his left main coronary artery up the lima, out the arm. And
Why is that, guys? Why is the arm stealing blood from the heart? Usually because the artery of the arm is blocked, and the lima is a way to kind of get blood from the heart to keep your arm going.
yeah, so this guy's lima comes off right here, right? You saw it going in the wrong direction. But this is actually a subclavian here. So this artery here should come up and connect here and go down the arm. But here I just have a dead end here, which I'm showing you. But that's not the cause of his heart attack, right? You told me it was an inferior STEMI. Here's the graft that connects down to the right coronary artery. There's certainly some native right coronary disease, but you can see this focal lesion right in the middle of the graft. And that was the reason that he had his heart attack. That's what got reperfused when the guy got thrombolytics. And in fact, you see that, fortunately, I made the right call because the guy's got blood flow there. The heart attack stopped. That thing's unstable, right? He's been on heparin for 24 hours now.
How old is the bypass graft?
Oh, I don't remember off the top of my head.
More than 5 years?
Yes.
Yeah, so bypass grafts get real crumbly plaque inside of them. And, you know, if you go in there and start messing that, what's going to happen to that? It's going to break up and go downstream, right? And so we used to be really scared about working in bypass grafts like this because they're so old and crumbly. And you're going to see here, I think, a different way of doing it.
Yeah, so you can see here, here's my catheter. This is a loop the surgeon puts around all three of the bypass grafts. And you can actually see down here that there's what we call a filter wire. So it's got a little miniature filter on it. So you put a regular wire down, you put that filter wire on, it follows the regular wire down into position, you unsheath the filter, and then you do all your work on the lesion, which was up here, if you recall, in the same standard fashion, blowing it up, putting some stents in, and then at the end you come back and retrieve the filter. And I showed you this shot already. Last case that I have, 71-year-old guy, limited follow-up, history of tobacco abuse, shows up with an hour of chest pain. So this guy's pretty early on into his heart attack. In the emergency room, rapidly recognized a STEMI loaded with aspirin, 4,000 units of heparin, which is appropriate. The Plavix dose, which we said was appropriate because the guy's 71 and less than 75 years old. And then the weight-based TN case, transferred emergently for consideration of PCI. Here's his EKG. Thoughts about that one? Pretty similar to the other one. Right, anterior ST elevation. Actually, question whether I put the same EKG, duplicated the slide rather than. But at periods of AIVR, became somewhat hypotensive. In the setting of hypotension and this off and on rhythm disturbance, I elected to just do him up front. He was going to be again a radial case, so we said. I think that was in fact his EKG. This is the first shot, right? Which artery is this? We said before. Exit C is the right coronary artery. Okay, and you can see there's the artery should be smooth, and it should, generally speaking, taper from be fat up here and then come down here. And there's this huge crunchy area which you can see wiggling back and forth. And that's clearly a problem, but I didn't think that was the acute problem, and this certainly would not explain an anterior ST elevation radial infarction. So here we go. This here again now is the circumflex. I told you the circumflex comes down in the first projection when we shoot the left. And you can see that this whole territory down here is actually that right that's being filled via his own little bypass grafts that he's growing around. So this shot now basically explains the whole thing, that right is chronic. That right lesion is chronic. He's grown himself some nice bypass grafts without having to go to surgery. And I'll show you here, this is the shot for the LAD, which is obviously what I'm concerned about with an anterior a heart attack, you can see again the right filling in, but this whole area is quite diseased. I'm going to just show this, not because you need to be able to interpret this, but this is actually a little ultrasound. So when we're dealing with calcified arteries or things that we're not sure are going to open up, we actually use this little ultrasound machine. Goes down and takes ultrasound pictures as it travels backwards. And let's see. So in about 1 second, you can see in the distal portion of the vessel, it's pretty round, right? It kind of comes up, you lose a little artifact here, particularly with the TV. But as you come upstream, all of a sudden that artery goes to nothing. There's no artery there. I mean, it's no bigger than the catheter that we pass down. And then you can come back upstream and see that, you know, this is all really unhealthy looking artery. And then it starts to get a little bit better and certainly a lot bigger when you get all the way upstream.
So stop there for a second. So, you know, it's like walking down a big drainage pipe, right? You're walking down that pipe with us. It's the inside the artery.
Sorry.
But it allows us to see how much plaque is filling the artery, how big the artery is. We can size the stents more accurately, tell if there's calcium there, if we need to go in and remove calcium first. So we literally can go down people's heart arteries and see inside the artery while they're watching the screen while we're doing it. And that can be very helpful, kind of help us learn how to put in stents better when they first come. And we use that frequently.
So here we go, there's one stent. He had too long of a lesion to treat with one stent, so there goes the second stent. And then I just put this in just because you'll be able to see here. So we're here again, marching along from the distal portion of the artery, climbing our way back up towards the ostium, towards the origin, towards the aorta. And you'll start to see kind of a hatch sort of pattern come on in here. And that'll be the stent. You saw a side branch come in up top there. You see a bunch of plaque in here. Here's big artery. And here's where I started to land that stent. So I landed the distal portion into healthy territory, which is what I want. The whole artery is diseased. You can see here as we go up that this stent is all kind of mushed in here, and we did a little more balloon work to try and mush it out. But this is the sort of imaging that we're kind of thinking about, trying to make sure that the stent is as perfect as it can be. And here's the final shot. You know, again, if you remember, this was a real kind of crunchy artery, and now it's big and plump and goes all the way down to the guy's apex. So I actually saw this guy today. He'll come back, we'll fix the circumflex in probably 2 weeks' time. But this was last week or 2 weeks ago. That's all I got. So hopefully that was a little operational and a little bit of an understanding of kind of the things that we deal with and do. So I'm certainly happy to answer questions or whatever the case may be.
You guys are 24 hours, 7 days a week?
Let's get let's do my presentation. Yeah. We'll tell you a little bit more about us.
I just want everybody to know that you guys are 24 hours, 7 days a week.
Yeah.
Are we gonna run out
365.
Say again?
We have been
Are we
since
gonna run out to
2017.
yours still?
Yeah, I think so.
Okay, so,
Was that working for other folks?
yeah.
Good. Hey, so Morgan's a nice guy. I'm not going to be nice to you guys. I'm going to pimp you. Okay. You know, you come here to do mega codes, right? So we're going to do one together here on a real case, a patient of mine that one of you all helped bring to the hospital. But let me tell you a little bit about the Billings Clinic Heart and Vascular. We don't live in Billings. Billings has really got a mission to try and take subspecialty care all throughout rural Montana towns, and they started in central Montana, and we're really their first big system development in southwestern Montana. Just going to move forward. So we actually have 4 interventional cardiologists. Dr. Waldo and I started first. Gene Silva is an interventional cardiologist too. All of us have been doing interventional cardiology for more than 20 years. We've done several thousand studies, and I actually was lucky. I was one of the first cardiologists to get trained in stents. The first stent was not a heart stent. It was an iliac hip artery stent. And I was a proctor for that, and then we developed heart stents after that. Morgan is probably our newest and greatest guy because he's had very advanced training in all the new devices and technology like Impella, ECMO, et cetera. We're hoping to bring that in soon to our center. We also have 2 non-invasive cardiologists, Matt Weiss and Carl Kingsley. And Gene kind of doubles as our EP guy. His EP is really his first love. He thinks anybody can do PCI, so he really works on EP mostly. But we have 2 cath labs now. We're doing all of these things kind of on a routine basis. Now, how can we do that without surgeons in the building? I mean, isn't that dangerous, guys? Okay, so most PCI centers do not have cardiac surgeons. I cannot remember the last time I sent anybody to emergency bypass surgery for a stenting. If you try to do that, the surgeon's going to go, "What? No. Open the artery with a balloon. Come on, man. We haven't done surgery for stenting in 25 years." So that's really, that's really not current state of the art, guys. We don't plan to have a cardiac surgery program, but this year we're probably going to do over 500 cases. So, with all the advances that have been made, particularly going through the wrist, all these therapies are so much safer. My love is actually endovascular. I'll show you one case today. That means working on all the blood vessels outside the heart, and now we can go through the wrist to do carotid stenting, mesenteric artery, intestinal stenting, getting down on the legs. We'll talk about that a little bit. Transradial wrist access, we're one of the leading centers in the Northwest now at community doing this. We're doing research and presenting at meetings on this. EP, we're offering a full service, as well as with non-invasive. We actually are trying to get out into rural communities and take all of these subspecialty skills that we have into places like Deer Lodge. We're in Helena, we're in Ronan, we're going down into Bitterroot, we're currently in Stevensville, getting ready to go to Sheridan, Wyoming, and we probably are going to reach out even further in the near future. These are all active clinics that we're having right now. And, I'm a big research guy. I was lucky to be involved in all the clinical trials looking at coronary stent, carotid stent, iliac stent, SFA stent approvals. And we're trying to continue some of that here because we really want to offer cutting edge treatments to all of our patients. So here's the mega code. All right. I'm going to pimp you this time. Yes. So, okay, this is a very, very common thing for you guys to see, I think. And that's going to the scene where you see somebody that's having nausea, maybe they're vomiting, they feel like crap, maybe their blood pressure's a little low, and you're always wondering, what's going on here? Could this be a heart attack, right? Let's talk about a patient of mine. She's 75, she's African American, she's a former ballerina, she's very tiny, she's about this tall, about 4'9", very slender, and she's been having constant kind of low-grade chest pain, back pain, really nauseated, it's vomited a couple times, really feels bad, and calls you guys to come and pick her up and help her, right? So you get her vitals, right? And she's got a low blood pressure. Her heart rate is kind of slow too, but her oxygen saturations are fine. She's not short of breath. She's not febrile. I figure out what's going on. Her lungs are clear, but she's got these really prominent neck veins. I mean, you can see them from across the room. She does have a murmur, and she says, yeah, my doctor says I have a narrowing of one of my heart valves, aortic stenosis. And her abdomen really is soft. She's not tender there. When you push on it, it doesn't make her feel bad. What are you guys thinking so far? Any ideas? Just throw out anything, because we're going to think about a lot of different stuff. Gastritis. How many times have you guys got called for that? She's not having any diarrhea. She hasn't had really any abdominal pain.
Did you say she's afebrile?
Afebrile, yeah. No coughing. Could it be COVID? Well, I was going to worry about that, right? Hasn't been vaccinated.
Fetal edema?
Nope, no edema, zero. She's very skinny. I mean, she walks around in high heels most of the time, but very, very skinny. So past medical history, she has had a coronary stent before. It's been a while, a few years in the right coronary. Again, she's had aortic stenosis. She knows she's missing a breast. She's had breast cancer, hypertension, but she's not hypertensive. And she's statin tolerant, okay? What else do you want to know?
She compliant with her meds?
She does. She takes her meds every day. She's very compliant. She's a good patient. As a matter of fact,
any med changes?
No med changes in the last, year. Okay.
Any valvular disease?
Here's the only med she's on, by the way. She's a very good historian and gives you all the information. She took everything today. She's on like 10 of lisinopril and 25 of metoprolol. She's, really tiny lady. So let's think about the differential diagnosis here, okay? I mentioned to you, COVID, come on, primary GI symptoms. You guys have picked up COVID patients. Almost everybody is having some kind of respiratory difficulty. She's having 0. We talked about, gallbladder. Can gallbladder do this? Well, yeah, but it doesn't cause you to be hypotensive, right? Unless you're septic or something already, but she was afebrile. Her abdomen was benign, right? Gastritis, maybe she's been vomiting, she's dehydrated. I don't know, that's something to think about. What about an aortic dissection? So if you've ever heard or seen an aortic dissection, it is really bad pain, and it's mostly going in your back. And sometimes there's a difference in blood pressure in both arms, so you got to kind of think about that a little bit. Right? What about pericarditis? Okay. Another thing, could she have pericardial tamponade? Why she's got a low blood pressure. It's not really pleuritic, it's really kind of constant pain. Or is it an MI? Well, you guys can all do EKGs, right? Let's do an EKG. Oh, look at this EKG, and hopefully it'll project. Well, maybe I have to turn the light down. And we're going to do exactly what Dr. Kellogg told us to do, right? We're going to look at the rhythm, and then we're going to look at the patterns. Remember anterior wall, V1, V2, V3, 5, 6, high lateral, inferior wall. What do you guys see? I'm going to yell out. Yeah, what's the rhythm here? Can you tell?
Can anyone find P waves?
All right, well, you guys can't see very well in the back. Let's get a magnified view of this, okay? Here we go. See, those are P waves, don't you think? Right? So let's just get a little marker quickly and mark out all the P waves. Those look like P waves. That's a P wave. Okay. Those are P waves, right? How do they correlate to the QRS? They don't seem to be carrying what the QRS is doing. Neither is the QRS carrying what the P waves are doing, right? So this is 30 baby block, right? So she's got high-grade heart block here. And now we know, oh, gee, there's something going on here with this lady's heart. This isn't COVID or gallbladder, and probably not a dissection or pericarditis. So what about STs? Where do you see some funny looking STs? Inferior, right? You can see it pretty easily if you look closely here. There's ST elevation here and there, right? So this is a acute ST elevation, infrawall myocardial infarction with complete heart block. You guys made the diagnosis already. Hopefully you've already called Dr. Kellogg, get him out of bed, or actually it's happening in the morning, to get the patient to the hospital. There's something else going on here too. It is important to look at other leads. There's some other things going on here. There's ST depression in the high lateral leads. And there's something going on here that I think is important to recognize, that V1 and V2, ST depression in the setting of an infrawall MI usually tells you what's going on in the back of the heart. So the back, something is going on in the back of the heart here too, okay? So what do you think the artery is gonna be? You're all good to be cardiologists tonight. Go out. Is it the LAD? No, it's the RCA, right? Good, you're right. Okay, so let's move forward, and there's a I think a magnified view there. So here's her angiogram. I'm not going to show videos, I'm sorry. These are normal angiograms of the LAD, left anterior descending, going around the front of the heart. Remember the orientation Dr. Kellogg taught you guys about. And then another view where we go up in the kind of above the left shoulder to look at those arteries. These are like pristine, beautiful arteries. But remember, she had a stent of the RCA, right? And I started worrying about that stent, and that's what we found. There was a 100% opening occlusion of her dominant, largest heart artery, okay? So she's kind of in trouble now. So she's telling you, I'm feeling sick again. Oh man, I'm feeling really bad. What are you guys gonna do? ACLS, what are you gonna do?
We're asking.
Okay, she's already had aspirin, but we like the idea of maybe having her chew and swallow for baby aspirin. If you can, she may throw it up. You gonna give her nitroglycerin? Why not? What is that?
I said the inferior, but also the blood pressure was.
Low blood pressure, right? Yeah. What about morphine? She's having this weird pain and everything. Okay. Okay. So you're not gonna give that. What are you gonna do for low blood pressure? Fluids. How much are you gonna give her?
Yeah, less is more, but
250, oh, come on, man, this is Montana, more is better, right? Yeah, this is a pretty hypotensive patient, and you're gonna learn to think in your mind a little bit more about these kind of cases. Clear lung fields, right? Not short of breath, low blood pressure, but we don't understand the JDD yet, the jeopardy pressure. Actually, this is a case where you want to give 500 cc's of fluid as fast as you can, and I'm gonna show you why in just a minute. So we activate Stally, right? You guys are close by. She comes in the emergency room. What do you want to do next? Go straight to the cath lab with her? Can we open up that? I mean, is this, we're not going to do, remember I called the surgeon, they said, what? Get the hell out of here. Go back there and open it with a balloon. Now, we're not going to do emergency surgery ever for STEMI in this community. So this is what we did. We did exactly what Dr. Kellogg shows you. We can get a guide wire to go through the blockage. In this case, I did use a catheter to pull clot out, to aspirate clot out. And then we reline it with stents. So she already had one layer of stents. Now we're creating a stent sandwich, right? Putting another layer of stents in there to try and get the artery open quickly, which we did. But there's something kind of funny looking about this artery. Where are all the branches that come off this artery? They've all been lost. And sometimes this happens when we layer stents. We lose branches. Where do those branches go in the right coronary artery? Go to the right side of the heart. And I'm going to give you a clue. They go to the right ventricle primarily. Okay? So we lost all those side branches, and we're all like, yeah, ready to high five. And the nurses go, wait a minute. She's not doing very well right now. Her blood pressure is 70 now. Her heart rate, she's still in complete heart block, right? And we happen to have the ability to measure hemodynamics. Her left heart pressures are very, very, very low. It's almost like she's dry, but her right heart pressures are about 10 times as great as they should be. So the pressures on the right side of the heart are extremely high. So how does the left side of the heart get blood? From the right side of the heart, right? The right side of the heart has to pump blood through the lungs and deliver it to the left side of the heart, okay? So there's a preload problem. We can't load the left side of the heart, right? Because everything's kind of stuck in the right heart. It's not coming out of there very well. And what does that usually mean that people are having? Well, it usually means they're having something to do with the right side of the heart, right? JVD and everything. Fortunately, you guys have brought her in. We can do an emergency echo on her. And this is an echo looking at the valve here. The heart's going to be pumping like this. The tip of the heart is up here. Here's the anterior septum. Here's the inferior wall. There's her aortic valve. Remember, she has aortic stenosis. And then during systole, she like has an 80% ejection fraction. This lady has got a super strong heart, Arnold Schwarzenegger heart, right? But the valve's not opening very well. But her left ventricle is working perfectly well. Why has she got such a low pressure? Well, it's because of this. There's another view. She's standing on her head. LV, LA. Look how big the right side of the heart is. This is a right ventricular myocardial infarction. So really kind of important to recognize because it leads to very severe hypotension, giving them nitrates, morphine, not giving them fluids. People can die from cardiogenic shock. So let's talk about this. It's 30 to 50% of all inferior wall MIs. So when you guys see an inferior wall MI, I want you to think, man, could this be an RV infarct? I got to kind of remember that. Maybe I need to give this person more fluids. It's usually due to 100% occlusion of the right coronary before all those little side branches that go to the right ventricle. The free wall becomes very hypokinetic, okay? And you really don't move blood into the left side of the heart very well. When the right heart dilates, it kind of pushes in on the left heart. That also reduces cardiac output. And usually these patients have shock with big engorged neck veins. And she had a really classic case of that. And they have no pulmonary congestion, right? Because there's not very much blood getting into the pulmonary circuit. Vagal symptoms are common. You actually have nerves on the underside of the heart that connect to the brain. And when you have inferior wall infarction or ischemia, and you've seen it before, a lot of nausea, vomiting, a lot of diaphoresis, sweating. 30-degree block is very common. We see this all the time. But it usually is a pretty stable rhythm, and it rarely needs a pacemaker. In fact, the ventricular pacing in this setting, when the heart rate's over 40 or 50, doesn't improve outcomes. ST elevation inferiorly, and you kind of, the clue is the reciprocal ST segment depression, sometimes in the anterior leads. You can do a right-sided EKG. I don't know if you guys have been taught how to do that, but D4R is kind of the best lead to pick this up if you do that. What's the initial therapy? Well, the initial things that they teach you in the mega codes to give these people are going to make her much worse, right? You got to recognize that, and that you don't want to make her go into worse shock and fibrillate. Fluid resuscitation is extremely important. Actually, it's recommended you give these patients, like I said, 500 cc's of saline as fast as you can. If you're going to start pushing blood now from the right side of the heart to the left side of the heart, they're going to be able to generate some systolic pressure. Dobutamine was used in her. We use it in a lot of these cases because dobutamine can make that right side of the heart start contract a little more strongly and generate better pressure. Plus, it reduces pulmonary vascular resistance, so it can get through the pulmonary circuit into the left side of the heart better. And pacemakers are almost never needed. We almost never get, because this usually resolves spontaneously on its own. So the good news is that with early intervention, almost everybody has their heart come back to normal with the right ventricle. And why is that? Well, the right ventricle it's a thinner walled muscle than the left ventricle. It's in a low pressure chamber. Remember, the right side of the heart usually has low pressure compared to the left side of the heart. There's some blood flow going into the muscle both during while the heart's squeezing and relaxing. On the left side of the heart, blood flow goes mainly when the heart's relaxing. For reasons we don't quite understand, the right ventricle can extract oxygen a lot better than the left ventricle. So right ventricular infarcts generally recover 100%. This is your EKG now. Can you guys tell me the rhythm and everything? So first of all, notice she's having some T-wave inversion here because she's still getting over her inferior right ventricular infarct. All the rest of the ST segments are normal, but look closely. Again, in the back, I know you guys can't see as well. Let's look at a different EKG here. This is a magnified one. You guys see the P waves now? So every QRS has a P wave in front of it. We didn't do anything but open the right coronary artery. Now this took a few days to come back, but it did come back 100%. So, hey, there's a lot of women here tonight. I think that's cool that you guys have so many women in your force here. And last month was, hey, go Red for Women. It kind of got forgotten in the middle of the COVID shit. But, I want to tell you a little bit about myocardial infarction in women. 50% of women have heart attacks before the age of 65. We take care of a lot of women with heart disease. The leading cause of MI in women happens to be cigarette smoking. We're trying to really help educate people about smoking, and there's a lot of smokers in Montana. The risk of death from a heart attack is 2 times greater for women than men. It's an important fact to remember that women generally do worse than men if they have MIs. And remember, the first symptoms are usually unusual. They're not the elephant on my chest, like you hear men say. Could be shortness of breath, my neck, back hurts, I feel nauseated, but indigestion, remember that. That's really something that should make you think inferior wall myocardial infarction until proven otherwise. If somebody can know that when you see them. Delay of onset, that's our biggest problem here. We're trying to really educate more people, get to the ER fast, activate the EMS system. We want to try and save your heart. We want to try and get you before the heart muscle dies. And we know that here in the first couple of years, this was like 2017, 18, only about 30, 40% of people even call you guys. A lot of people in Montana just get in the car and start driving, or their truck, which is crazy, but that that happens very commonly. The thing that I want to talk about, and we'll get to this in just a minute, is that women's risk for bleeding and having complications from femoral access is almost 5 times greater than men. And that's going to lead just talking about what's called the radio revolution.
Dr. Meyer, can I ask you just one question about
Sure.
that patient? Is there any, we only carry Levofed as our pressure. Does that have any value after the bolus? The pressure doesn't come up with Levofed.
Yeah, it would definitely help because Levofed is going to activate the right ventricle a little bit too. Absolutely. Yeah, so if you get a profoundly hypertensive patient not responding to fluids, absolutely, we support that 100%. So the radio revolution is actually something we didn't do. We're behind the rest of the world in this. This is actually something that started in Europe because it's so much cheaper to do CAS through the wrist than the groin, and you're going to learn so much safer. In Europe and Asia, it's done in over 70% of every case for PCI and coronary angiography. How are we doing in the United States? It's a lot less. It's something that's a little bit harder to learn. I wasn't trained in it, Dr. Kellogg was, but it is trickier to do and it's harder to learn. But there's a lot of good reasons to do it. We're really big on it. That community, we're doing almost 90% of all of our cases that way. One of the main reasons why is we just don't have people have to spend the night in the hospital when they have elective cases. They go home the same day. There's lots of studies done on all the European use of this, and we were looking at, thousands and thousands of patients, and we saw that there was a 70% reduction in access complications. I don't know if any of you guys have been around and seen somebody's groin after a cath, the big bruise, somebody's had to stand on their groin for 5 hours, et cetera, et cetera. For the wrist, you just have to put your finger over the dot, right? And you heard about the wristbands that we're using that have inflatable cuffs in them. But most importantly, and we're trying to figure this out, it seems that STEMI cases live longer if you do the same thing, but you use the wrist instead of the groin. And maybe because we're not weaving behind all the different organ systems in our body and all 4 brain arteries to get to the heart. We're just going by 2 brain arteries, the vertebral and carotid. So it seems like you can live longer if you go to a place that's doing STEMI intervention by your wrist instead of the groin. We've learned that it's cheaper, you're not using closure devices, et cetera, et cetera. It's probably that you even save more than that if you send them home the same day for elective cases. And if you talk to any patient or any cath lab nurse, they're going to go, hey, I love using the wrist, because when you use the groin, people have pain and you give them narcotics, and then they vomit, right? And then their groin bleeds again, and then they can't pee, and you got to put a Foley into them. And then, you're waiting and waiting to let them off their bed. So when we go through the wrist, people go and sit down to get coffee, and they say, Doc, I gotta go to the bathroom. I go, well, it's down the hallway on the right. Seriously, that's how we do cases now. Why perform any PCI using femoral access? That is a really good question today. It saves money, it's safer, patients like it better, nurses like it better, and there may be a mortality benefit. So, especially for women, I really, really want to try and do these cases through the wrist whenever possible because of all these benefits. So yeah, should all cardiologists become a radialist? I kind of think of myself as a radialist. Yeah, I think we should, because we miniaturize everything. We have nanotechnology, all the things you saw today, everything we've done today, we can do all through the wrist, and we do routinely. So here's a case of someone who recently was treated at our institution through the wrist, and this isn't an acute MI. It's just to give you an idea of what can be done. This is a 69-year-old who had a very sick lady, heart failure, blood pressure high, high cholesterol. Aren't there only 3 arteries to the heart? She had 4, and all 4 had severe blockages, and she had a low ejection fraction. Remember, the heart pumps like it bellows, 60% with each beat. Hers was half of that. She had a prior stroke, and she was scared to death of coronary bypass graft surgery. Now, she's from the Bitterroot, but we won't say too much about that. But, she had really strong feelings about not going to bypass surgery. You can see her problem. She had a critical right coronary lesion. Okay, the LAD right here is almost totally gone. It's just a thread. And then her circumflex and her ramus here are also severely diseased. So the Syntax trial, maybe you guys should know this. This was done many years ago. I was one of the investigators. They looked at people that had severe blockages in all their heart, and we said, all right, flip a coin. Heads, you're going to get bypass surgery like you always did. Tails, you're going to get drug-coated stents instead. And that trial showed us that actually it's better to do stents than surgery for most people if they have focal blockages that can be treated with stents. The risk of stroke is a lot less. You can do it as an outpatient, as I'm going to show you here. So, that's why the surgical specialty in the heart is really getting into doing valve stuff more now. We don't do bypass surgery that much anymore. This is a case where stents were used for all the blockages. So she came in one day, she got her angiogram, she said, I want to go home. So she went home about 11 o'clock in the morning, went through the wrist, and we talked about it, and talked about surgery and about this trial and stents, and she decided she wanted to have stents. So the second day she came back, we fixed the right coronary artery. Okay, 1 stent was used here, and we were able to get through that left anterior descending coronary artery and use stents. And she went home that afternoon. So again, she's never spent the night in the hospital. The last time she came back, we finished up with Stents here, and if you look closely, you'll see the stents on the angiogram. Maybe you can't see it there, but you can see the stents here. So this is a lady that never spent the night in the hospital, never saw a heart surgeon, had everything done through the same wrist, all with just a same-day visit to the hospital. So remember I told you her heart muscle function was really bad. Did it help her? Well, let's see if I can play this. So here we are at the beginning. This is a pleural effusion back here behind the heart, big pleural effusion. Here's the inferior wall, here's the anterior wall, it's barely moving. Here's the mitral valve opening, closing. Remember the heart's pumping in this direction. That's before we stented her, and this is after. And you can see how it completely normalized. So she had the latest technology. Remember, this technology, since I first started using it in '92, has really come a long way. It's no longer clunky steel stents. It's these really sophisticated chromium cobalt stents that are thinner and stronger than stainless steel, come in different lengths, can go around hairpin curves, and are coated with a polymer that has drug in it. And that drug came from breast cancer treatment, believe it or not. So the first drug we used in drug-eluting stents was from a breast cancer drug called tamoxifen. It's called a Taxol stent. Now we've developed that drug, so it's similar to chemotherapeutic drugs, but it blocks scar tissue from forming. And all of hers were drug-eluting stents, as are all the stents we put in pretty much these days. So one more fun story. This is a 71-year-old who had a STEMI done at her institution, used the right radial artery, and she just really wants to change her life. She really wants to get into cardiac rehab. We want everybody to get into cardiac rehab. You participate in a full cardiac rehab program, it improves your quality of life, and it reduces future healthcare costs and future needs for other types of procedures. But she couldn't do it because she had really bad buttock and leg pain whenever she tried to walk, right? That's like angina of the leg muscles, right? And this is why. So this is from her wrist, and this is a picture of the aorta. You're going to see the kidneys at the top, see the kidney beans? And as you look down the aorta, as blood flows to the hip artery, she's got some blockages in her abdominal aorta, right? This isn't an aneurysm. This is the other way. This is getting blockages in your abdominal aorta. Now, this used to be a surgical problem, right? Where you'd have to come in, cut open your belly, build bypasses around the blockages. She had this treated as an outpatient, never spent the night in the hospital for this. Let's show you how we did it. So again, going through the wrist, we were able to treat both these blockages. This is an endovascular procedure. You can see how the guide wire is coming down the center of the aorta. There are the stents going in here. And she actually really didn't like being put to sleep. So we did this with zero anesthesia. We just used lidocaine in her wrist. So we were able to stent her aorta, and she went home that day, and she is now somebody that hikes on Blue Mountain and is doing great. And we've actually are very interested in trying to promote this. This is a relatively new thing to do in the United States, to use the wrist to treat blockages outside the heart. We have a lot of experience doing this, and actually a couple of years now, we presented at one of the largest endovascular meetings in New York City about how safe it is to do this as an outpatient therapy, and we pursue this every day now. So looking at our future, I think we're going to use transradial access for everything, okay? And the reason is that, again, it's safer, it's cheaper, and patients really prefer it. And in this day of COVID and other infections, who wants to spend the night in the hospital? Nobody does. So for elective procedures, we really don't admit any patients now because they can go home after transradial access. We're getting to the end here. I'm so glad we all live in the last best place. Hopefully it stays that way for a while, right? We all have to watch out for these guys, but this is kind of what Morgan and I are hoping to develop soon. Go to McDonald's, but then, come on over to our place, sit out your wrist, we'll do any angiograms, you need a stent, you get one, and you can drive home, okay? So maybe that'll be the future of cardiology. All right, thanks.
Just in your experience with our crews, do you have any feedback for us on things you'd like to see us doing? I think you give us really good guidelines.
Reactivate. There's no reason the patient should be waiting for us to get out of bed, particularly if you know it's standing up. If it's, again, it includes the middle of the day. Because again, the labs don't sit there empty by and large. People are going and there's always some juggling or study comes in. So, but it's worth doing, and we illustrated why. But definitely The more heads up, the better. Even if it's wrong, you know, reality is we're gonna be in there to see the patient anyways. So if we're called by you guys, or called by the ER, or it's gonna be called anyway. So if you're worried, reactivate. Get that ball rolling. And then I think my, the other thing is really, we want to know when you're going to the cath lab in particular, which is kind of the focus of this evening, the things that can get us in a bind are things, that we kind of talked about already a little bit, but things like aspirin allergy. If someone really truly has anaphylaxis to aspirin, that's important that we know that. If somebody has active bleeding, that's important that we know that. I and probably some folks here have kind of been with me as we're walking from the ambulance bay. I have a whole line of questions I run through, and from the time you last date to any history of trouble with anesthesia, any reason you wouldn't be able to get blood transfusion, any reason you couldn't take aspirin. There's a whole line of questions, and it basically kind of comes out in one statement. And I trust that the patient's keeping up with me, but the reality is that these guys, people coming in the cath lab are sick, and you guys often have more time, frankly, often a lot more time with them than we do to make the decision. So, hey doc, just want to let you know that, he said, he got allergic the last time they gave him contrast. I think my point for tonight is you don't need to know how to do a CAT, but you should have some understanding of what it is we're going to do when you hand that patient off, and I think we illustrated a little bit of that. But also, that includes we're going to use X-ray contrast. We're going to need blood thinners. We put everybody on heparin in their cath lab. People are going to be on long-term antiplatelet therapies, aspirin and Plavix typically, or aspirin and Valentic, Aguilar. If you pick somebody up afterwards, don't just stop their aspirin. I mean, that's a little less, it's more from a nursing side than from an EMS side, but, and then I think, giving the flavor of the patient before they get there is helpful, right? So if somebody's, coming in pain-free, hemodynamically stable, the clock's still running for me. I mean, that's still a presumed blocked artery until it's, proved not to be blocked, chest pain 3 greater than 50% ST elevation resolution. But it's helpful for us to the best that we can. I mean, sometimes we don't get this opportunity, but say, hey, blood pressure is good, and we're feeling well, and just me on my way 20 minutes ago, that's super helpful for me. Alternatively, hey, unstable, and by the way, we just started coding it. That's also information because it affects what equipment we pull out. It affects what we're thinking about, what meds, who's going to be there. Do I need respiratory? Do I need anesthesia to intubate? Do I need a vent in the room? Those are all sort of things that are, we don't usually have a vent in the room. Basically, we never need a vent in the room, but sometimes we do if it's not a hospital arrest.
Yeah, I guess I just want to empower you guys. You all are excellently trained professionals. You cover stuff and know stuff I don't even know, or I don't even want to know about kids and all that thing. But you can get really good and as good as me and Morgan at reading EKGs and recognizing ST elevation patterns and things. And do what you think's right for the patient. If they're coming our way, we're just it's like a tag team. You're gonna hand it off to us. We're gonna pick up where you left off. We really want you guys to do what you're trained to do. But yeah, I think the one thing I want to leave you with is getting people as quickly as you can to either us or St. Pat's. Personally, I come from Illinois. In Illinois, it was illegal to drive by a PCI center to go to another one because door-to-balloon time was such an important focus for all the institutions. So yeah, if I was having a heart attack on the other side of town and my hospital was further away than the closest one, they would take me to the closest one because we know that extra time, 15 minutes, 30 minutes, whatever, can really hurt you. If you can get people in faster one place or the other, you should. So time for us is really important. The faster we can get people, especially in that first 4 hours, the more likely we're going to see them back like this lady, and the heart's going to be normal. Yeah, the hard thing for me is people getting to us late, either for their fault or whatever, and they're left with really bad hearts. You know, sure, they get stents, oh, isn't that cool, it's beautiful, but their ejection fraction is 20%, you know, and they're young. Oh my God, you know, then you gotta talk about drugs and defibrillators and all that stuff. So we want to get people in as soon as we can to any PCI center that's available to you, because that gives us the best chance of getting the area open and saving their heart from being really sick afterwards.
I think the last thing I would say is just a reminder that when you're in the cath lab, anything blue is sterile. So come on right in, you don't need to get dressed, you don't need to put scrubs on, you don't need to have pats on or something like that, but just stay, don't touch the blue stuff. And anybody is always welcome to stay for the case. And anybody who's worked with me kind of knows that I'll always invite everybody to stay. We're obviously on X-ray, there's a control room in both cath labs. You can go in there. You don't need to have lead on. You're welcome to put lead on if you'd like to be a little closer, but if you're outside of the control room, and that's true, you know, frankly, if you wanted to come and spend a day and just kind of see what happens, we're open to that too.
You guys prescribe Coumadin as much as it used to be, or is it newer?
So Coumadin's obviously a anticoagulant, and for stents, we're really worried about platelet aggregation. So by and large, with the exception of mechanical valves, I basically don't use Coumadin outside of a couple of limited circumstances. You know, the advantages of Coumadin is it's really, really cheap for the pill itself. You know, it's not inclusive of INR testing to see how thin the blood is, but it's not adequate for a fresh stent. So aspirin and Plavix or aspirin and Brilinta, clopidogrel, ticagrelor are the generic names.
That's a good question. I mean, I'm one of the old guys in the room, right? I was putting in stents when they first came out, and we didn't know what to do. We were giving them everything. We gave them Coumadin, aspirin, we had something called Quercetin back then, and Coumadin led to everybody clotting off their stents because it doesn't affect the platelet. The platelet's the bad guy. And now all of our therapy is targeted at platelets. Now, you may have some people that have atrial fibrillation or mechanical valve, and they get 3 drugs when they first leave the hospital: aspirin, Plavix, and Coumadin or Eliquis or that sort of thing. But we're now learning we don't have to keep them on all 3 for very long. We'll take away aspirin pretty soon after they're started on that because of the bleeding issues. You know, but yeah, we don't use Coumadin very much. You know, the diet changes it. Your finger's stuck all the time. It goes up and down. We're using the newer drugs, the novel oral anticoagulants like Xarelto and Eliquis, because they give you a real nice even blood thinning. They're a lot